This topic is blood transfusion. Blood transfusions replace lost blood or cellular components, often after surgery, trauma, or anything else that's causing hemorrhage. The purpose of a blood transfusion is often to increase our red blood cells, and in clients with anemia, to maintain or increase our hemoglobin. Now, when we say blood transfusion, we can be referring to a number of different products. The first are packed red blood cells. These are often given to those clients with symptomatic anemia and are going to raise our hemoglobin and hematocrit. We give fresh frozen plasma, or FFP, to clients who have a deficiency in clotting factors, such as clients with Disseminated Intravascular Coagulation, or DIC. Frozen RBCs are often used for autologous transfusions, or the client transfusing blood to themselves. If clients have a rare blood type or specific alloantibodies, we may want to take blood from them prior to surgery or treatment that we can give back to them later. Freezing the red blood cells preserves them for longer and helps the client have available blood if needed. If clients are experiencing thrombocytopenia or a low platelet count, we can administer platelets. This is usually related to bleeding. Albumin is a plasma protein that's going to expand our blood volume. Unlike other blood products, albumin is shelf stable and actually can last for up to 5 years. We don't need to use blood tubing or follow the same rules with blood transfusions for albumin. Finally, we can give clotting factors such as cryoprecipitate for clients who are lacking in clotting factors. One of the most important roles of the nurse in administering blood products is verifying ABO and RH compatibility. We have to verify that the blood the client is receiving is compatible with their own blood to help prevent life-threatening transfusion reactions. We're not going to go through the whole table, but I want to highlight a couple things in our image here. First, let's look at type O blood, known as the universal donor. Type O blood will not have any surface antigens present, but it's going to have both anti-A and anti-B antibodies. Because there are no surface antigens on type O blood, the blood will not interfere with other types. This is why type O blood is the universal donor. On the other hand, we have type AB blood, which is going to be our universal recipient. Type AB blood is going to have both A and B surface antigens, but no antibodies. This means that if we give them blood from a client who is type A, type B, or type O, it's not going to interfere with the blood because the antigens are already present on the surface. So we talked about type O and we talked about type AB, and now let's look at A and B. The same rules are going to apply here. Type A is going to have A-type surface antigens and anti-B antibodies. This means they can donate to other people who are type A or those who are type AB. They can receive from other people who are A or from people who are type O blood because, again, type O blood will have no antigens on the surface of the blood. Similarly, clients who are type B are going to have a type B surface antigen, and they're going to have anti-A antibodies. They can donate to other people who are type B or to those who are type AB. They can receive from those who are type B or those who are type O. When we refer to someone's blood type, you'll often hear positive or negative in there. You may hear A negative or AB positive. So what does that mean? Well, let's look at the columns here for Rh positive and Rh negative. Clients who are Rh positive are going to have a D surface antigen and no antibodies in the serum. This means they can donate to other people who are Rh positive, but they can receive from those who are Rh positive or negative. If someone is Rh negative, there is no D surface antigen, but there are anti-D antibodies. Because there is nothing on the surface of this cell, they can donate to someone who is positive or negative, but they can only receive from someone who is negative. Blood transfusions are going to require specific equipment. First and foremost, clients are going to need IV access. If possible, we'd like to have a larger bore IV in a client such as an 18 gauge, but it's not always necessary. Studies have actually shown that small gauge IVs such as 22 or 24 can infuse blood products just as well as larger gauge. It used to be thought that these larger gauges were going to help prevent hemolysis or blood cell destruction, but studies have shown that there actually isn't any more destruction of cells in a small catheter. For blood, we need to use a filtered Y-type tubing. As you can see in the graphic here, the Y-type tubing is going to have 2 spikes. The first spike will go into our 0.9% sodium chloride, or normal saline. The other spike is going to go in the bag of blood. Both tubes are going to have a roller clamp, so we can stop the flow of one bag or the other. Additionally, this tubing is going to have a drip chamber with an inline clot filter. to help filter out any clots that are in the blood from getting to the client. Finally, with blood products, it's very important to use an infusion pump. We need to make sure we can monitor the rate of infusion and deliver it properly to the client. If blood takes too long to transfuse, bacteria can begin to grow. And when we start a blood transfusion, we need to start it at a slower rate than we're going to end up at, so we can make sure the client is not going to have a reaction. Using an infusion pump is going to ensure that the blood is delivered to the client at exactly the rate we want it to. It's very important to remember that normal saline is the only fluid compatible with blood products. You should never administer blood products with another fluid connected to the wide tubing. Additionally, we are never going to add medications to the blood products or into the tubing of the blood products. If you're going to be giving multiple units of blood, it's very important that each unit of blood uses a different set of tubing. Remember, blood can only be at room temperature so long before it's no longer safe to give. If we're using the same sets of tubing over and over again, we're going to have old blood in the tubing that has been sitting out for too long and may be growing bacteria. We'll talk more about verifying blood with another nurse later, but I want to mention now that it's very important that we check the blood bag for the date of expiration. Some blood products are going to have a very short shelf life, especially those that were frozen and thawed. We need to make sure we are still in that window to use. We also need to inspect the integrity of the bag. We need to look for leaks, changes in blood color, clots, or bubbles. If you suspect that the bag has been compromised in any way, do not give the blood and return it to the blood bank. You need to prioritize your client's safety and help prevent infection. Blood should be administered within 20 or 30 minutes of receiving from the blood bank. If for whatever reason you can't administer it then, you need to return it so they can refrigerate it properly. And it may sound silly, but please, please, please do not put blood in a refrigerator other than the designated refrigerator in the blood bank. Like I mentioned, one of the biggest components of blood administration with a client is maintaining safety and preventing infection. So we need to first verify consent. Now, it gets kind of tricky if it's an emergency situation where the client cannot give consent. In that case, the physician would act in the client's best interest. But if the transfusion is non-emergent, we need to make sure the client has signed consents and understands exactly what they're getting blood for, as well as what products they're getting. With another nurse at the bedside, you need to verify at least 2 client identifiers, such as name, date of birth, or medical record number. It's also very important that we verify the client's blood type as well as the donor blood type and that they are compatible. With another nurse, you need to review things like the expiration date as well as the unit number to ensure that what was supposed to be given to the client is actually what's about to be given to them. As I mentioned earlier, we need to have IV access. Ideally, we'd like to have 2, but if we only have 1 IV access, that's okay. Now, your facility's rules may be a little different, but ideally blood should always be administered between 2 and 4 hours. Like I said earlier, if blood stays out too long, we run the risk of growing bacteria, and we don't want to introduce additional bacteria into a client. Prior to starting a transfusion, you need to collect baseline vital signs, so things like heart rate and blood pressure, temperature, and respiratory rate. You also need to check the vital signs 15 minutes after the infusion starts and at least every hour. As the nurse, you need to stay with the client during the first 15 minutes to observe for transfusion reactions or other complications. And very important to note, this is not something that can be delegated to an LPN. You must, as the RN, stay with the client and complete the documentation. In addition to transfusion reactions, there are some other complications we need to look out for. Circulatory overload, which we discuss in detail in our transfusion-associated circulatory overload video, as sepsis, because like I said, bacteria can enter the bloodstream through the blood, and rarely infection transmission such as HIV or hepatitis. For all clients receiving blood transfusions, we need to monitor their electrolytes. But for clients receiving massive transfusion, this is especially important. If clients are receiving large amounts of blood, they're going to have disruptions in their electrolyte levels. Blood is often preserved with something called citrate. Citrate binds to calcium, which will reduce our levels and cause hypocalcemia. Additionally, anytime a cell bursts or lyses, it's going to release potassium into the bloodstream. Now, this is always happening normally in the body, but when we're introducing extra blood into the body, it's going to happen even more. So we need to monitor for both hypocalcemia and hyperkalemia and treat accordingly. The biggest complication you need to be aware of with a blood transfusion is a transfusion reaction. Now, there are lots of different kinds of transfusion reactions, some occurring immediately and some occurring even after the blood is done transfusing. but they're all going to start with the same symptoms. Clients may report chills, or they may have a fever. They may have itching, a rash, or even hives. Sometimes clients may report a shortness of breath or chest tightness. If you recognize these signs or symptoms in the client, you need to immediately stop the transfusion. The blood tubing needs to be disconnected from the IV, but very importantly, do not remove the IV. It's very important that you do not flush out the blood in the tubing into the client. If they're having a reaction to the blood, we don't want to introduce more of that blood to the body because it will further the reaction. After you disconnect the blood tubing, you need to infuse normal saline with new tubing into the client. Infusing normal saline is going to increase our circulating volume and help filter out anything that was introduced to cause the reaction. Very, very importantly, do not leave the client. You need to monitor their vital signs at least every 5 minutes. We especially need to monitor things like the airway if they're having an anaphylactic reaction, and we need to administer emergency medications if prescribed, such as epinephrine for an anaphylactic reaction. We need to also collect blood and urine specimens. Blood and urine specimens are going to help us see if there's anything else going on inside the body, and especially if this reaction has caused any of our cells to lyse or burst. Urinalysis can also help us monitor kidney function. If for some reason the transfusion reaction has injured the kidneys at all, we're going to see this displayed in the urinalysis. If clients have a reaction, do not throw away the blood bag or the tubing. We need to make sure we return everything that we had to the blood bank for further testing. Finally, we need to document appropriately and accordingly. We need to make sure we documented exactly what happened, as well as the client's vital signs and an assessment of the client during the reaction. You also need to make sure you notify the appropriate people. So we need to notify the healthcare provider and our charge nurse at the very least to make sure that we have completed everything properly.